permission, we are going live, sir.
Yeah, sure.
Hi, Rocky, please let me know once we are live. Are we live? From the HiDoc team, can you please confirm if we are live?
We are live, sir.
Yeah, thank you. A very good evening to all. On behalf of Pfizer, my name is Sanjay Prakash. I am the Regional Business Manager with Pfizer. I extend a very warm welcome to all the respected faculty members to this very important virtual meeting. And I also extend a welcome to all the healthcare professionals who have connected to this meeting from the southern part of the country in particular. I take this opportunity to welcome you all for the Manthan meeting this evening. Today, to discuss this very important meeting, the meeting would be moderated by Dr. Pawan Kumar Boyala, sir. He is joined with Dr. Santosh Devdas, sir, and Dr. Madhav Dantala, sir, from Hyderabad and Bengaluru. It's my privilege to introduce Dr. Pawan Kumar Boyala, sir, who is a consultant medical oncologist and BMT physician at the Basavatarakam Indo-American Cancer Hospital at Hyderabad. Joined with him is Dr. Santosh Kumar Devdas, sir, who's an assistant professor and senior consultant medical oncologist and BMT physician at the Department of Medical Oncology at MS Ramaya Institute of Medical Sciences, Bengaluru. And Dr. Madhav Dantala, sir, who is a consultant hematologist and BMT physician at Yashoda Hospital, Hyderabad. I'm sure over the last 8 years, which has seen a rapid expansion of the salvage options for treatments for the patients with relapsed and refractory ALL, the efficacy of the targeted approaches has shown to outweigh the conventional chemotherapeutic regimens with the reduced toxicity as well. Today, to discuss more on the careful consideration which is required now, we would have a panel of discussions which would be moderated by Dr. Pawan Kumar Boyala, sir. Sir, over to you for your moderation and talk from here. Thank you.
Yeah. Hi, thank you, Sanjay. I think we are in, and welcome Santosh and Dr. Madhav. I think we know each other. So let's keep it more informal discussion. Probably everybody has changed from the photos which has put forward there. Nobody looks the same. Yeah. I think Madhav's video is still loading, probably. I'll just share my screen. Yeah. Yeah. I think my screen is visible.
Yes, sir.
Yeah. Good evening, everyone. So, as things have evolved and with only inotuzumab available in India, and that's the main drug which probably has transformed the treatment in relapsed adult BB-ALL, and probably will take it from here. So, as dictum, so how many patients we see in a regular practice? So, I think we'll start with Santosh. So, how many patients do you see in adult ALL in a year in your center in MS Ramaya?
Maybe about 25-30 patients. Yeah.
Okay.
We are a teaching hospital, so
I totally agree.
We see quite a bit of. Yeah.
So you practice both pediatrics and adult, or you take care of the adult?
No. We have a pediatric colleague, so.
Okay. Dr. Madhav, hope I'm audible.
Yeah, I mean, I know you're aware that I've recently switched hospitals, so I don't see so many numbers. But I mean, in the past, like in Manipal, at least I used to see a lot more pediatrics than adult. I would say like roughly a 70-30 split. Like see more pediatric ALLs than adult ALLs.
So probably even I am in a part of panel. So we are in a more like a teaching institute, like something like MS Ramaya. But we have a big group of colleagues. We have almost 13 medical oncologists working with residency program running. So we as a group probably will see So more than 100 patients, adult, I'm saying again adult, more than 100, 100 is also probably a number, 150 to 200 patients in a year with adult ALL coming into picture. I take care of the hemato-oncology stuff, so probably as a East consultant, probably same, like 30, 40 patients a year, new patients coming into adult ALL. And what are the proportions of patients we actually see in a relapse refractory setting in your center of Santosh? Adult ALL.
Yes, surprisingly, for some reason, we see even less relapse patients. Most of our patients are doing well after the initial therapy. So I was very surprised with what we are seeing here compared to what I saw in my training. Where a lot more percentage was lot more patients used to relapse. Overall here, the number of patients who relapse, though the number is nearly for 50 to 60%, our number may be to the tune of 20-30%. So it's a lesser number of patients who seem to be relapsing for a strange reason. I'm not sure why. Because the protocols are same, everything is same. Maybe the biology is different in South India.
That's correct. That's Madhav, you want to add something?
I think I don't have numbers to speak about, but I think I would say around 30 to 40% is the usual like relapse rates that I've seen like in the last 5 years at least. It would be around 40%.
Sin, the problem again, it's again institution bias, which is always there. We work in a setup where we tend to see a lot of patients because of the schemes, government schemes we tend to have and all those things. Probably our patients relapsing, yes, 10, 15% patients, 20% patients relapse, but we tend to get referrals from other institutions once they relapse. Financial issues, they come back for the financial issues. Yeah. So we per se see almost new patients, new relapsed adult ALL somewhere around 30 patients a year, 30 or 20-30% patients coming up. But most of the patients are actually coming from other institution, even our institution. I think everybody is same. Probably like Santosh institution right now, probably are able to give the full protocol on a time, or probably biology of the disease, something like that. So actually the data from all over the country, we almost have somewhere around 25 to 50% of the patients who relapse. And even the BFM, the hyper-CVAD groups, which have actually concluded adult ALL, the 5-year overall survival is somewhere around 37%. That's 1/3 of our patients actually survive for 5 years without a relapse. That's a staggering bad number. And things have evolved over years. The pediatric groups have taken it forward. The adult groups also, over the years, with the age groups, which are younger age groups, did better. So survival, almost 5-year survival has gone up to 30-40% compared to the previous era. And now probably the biology of disease in adult ALL defines our whole scenario, where we have 2/3 of our patients tend to have some sort of bad biology, a pH-like or a pH-positive ALL, which have been an issue, which were not found out before. And now, with the new availability of NGS and new modalities, I think we are going ahead and finding out and probably offering a transplant. Again, a question from here: how many of us in an institution, Santosh, like, are we using NGS upfront for ALLs, or we are still sticking to our typical pH positive MLL or other stock fish panel which we sent before with the karyotype?
We are, if it is a BALL, definitely we are pushing for a full NGS, and nearly 80 to 90% of patients do have a full NGS. However, if it is a TALL, we are not so strict. We tend to just get away with a conventional cytogenetics, and if required, a BCR, ABL, PCR.
So, Madhav, from your side?
I try pushing it for my adult ALLs, not so much for the pediatric ALLs though. The adult BALLs, I try pushing for the NGS.
So unfortunately, we are in a center where, again, the financial issues and all. So most of the government scheme and other schemes, the NGS is not covered. So we have in-house fish panels, so we tend to push for it. Probably some patients, lately we are starting doing NGS. So we are actually lacking behind in that scenario. So usual diagnostic tests, I think we are very clear on that. Most of us, we do. And as a question, are we looking at CD22 as a flow cytometry panel in your institution? Santosh, you can start.
In a relapsed CLLS,
Okay.
in a relapsed CLL, I would like to, I wouldn't really look at it in upfront setting.
Correct. Madhav,
they've included it, the CD22 even in the upfront flow panel, like this, the panel that is designed.
Yeah, I think it's more like an institutional protocol of adding the panel. Correct.
Yeah, so they've included CD22 in the panel. That's done even in the upfront setting.
So yeah, so you probably will not give importance to it an upfront setting, but relapse setting probably will do. Yeah. So most of the protocols CD22. I think we are agreeing on the same. Most of the questions I probably will not keep it too simple. I think let's go into the more discussion. Okay, the commonest point, yes, relapses are low, but I think everybody has the medullary relapse as the common side. And how often are you seeing the so-called very early relapse patients in your setting? Madhav, to start.
Yeah, very less.
Yeah, Santosh, yeah. Who are you?
Yeah. So it's early relapses, again, relapses themselves seem to be rare for some reason. So early relapses are even less. So out of 10 patients who relapse, maybe 2 or 3 patients would relapse early.
Madhav?
Same was, I mean, I kind of have the same thing that, I don't see a lot of very early relapses, like within the first year or so.
I think it's very early relapse has been almost very less, probably a single digit, less than 10% or 5% or something. So most of the patients probably we never find I'm again saying we never had this NGS concept lately from 3-4 months. So most of I have some almost 5% to 6% patients. Yearly from 3-4 patients will be early relapse. So retrospectively, again, we do NGS when they relapse. So we actually found them to be pH-like pathology, pH-like genetics, cytogenetics. I think the same thing. So most of the patients who relapse tend to do bad, 7% 5-year survival. And I think it's too much. I mean, it's clearly understood. So how they do? I will just skip this part. Yeah. Now coming to the current option. So we have a patient who has relapsed, early relapse or so-called relapse after 2 years, a single scenario. Now with the availability of 3 regimens. So we have a chemotherapy apart and we have inotuzumab, blinatumomab and CAR-T. CAR-T is still in its nascent stage in Indian scenario. So what is an option for you available right now in India? If you take chemotherapy, inotuzumab or blinatumomab? Santosh?
So I would definitely choose to use inotuzumab because of various reasons, and in terms of toxicity and in terms of convenience. Definitely, CAR-T would be a definite competitor for inotuzumab.
Madhav, you want to add something? Your perspective?
I haven't used Blina since like coming back, but definitely, I mean, having used both the drugs, and I've also had some experience with CAR-Ts as well because we had an ongoing trial over there in Vancouver.
Okay.
Inotuzumab is definitely the easier of the lot. Like, I would definitely prefer using inotuzumab.
So I'll come back to this question probably in a transparent setting again. So anyway, so our whole intent with availability of inotuzumab, probably we are chemotherapy, we'll keep it a second option in adults.
Again, if I may add again, Blina, I think the most common setting that we've used it is like an MRD eraser of sort.
Correct.
When we're taking them to transplant, in that setting, we've definitely preferred to use Blina, but other settings, like if you're looking at a relapse and in those settings, inotuzumab definitely.
If CAR-T is available, I think what will be your choice? CAR-T is available already. We have a CAR-T as proven, but CAR-T is saying he'll only use after 2 lines of treatment.
Yeah, I would still reserve CAR-T for later.
No, then you use Blina or inotuzumab because always the CD19, you use a Blina upfront, you cannot use a CAR-T. That's also a scenario because most of the Western world, till my knowledge, many are avoiding blinatumomab because if the CAR-T is there, that you use a CD19 anti-CD19 antibody before CAR-T, they are out of the trial.
Yes.
And probably you worked in a setup, you have a trial. That's the reason I'm asking.
Yeah, so I remember we had a patient who Hadn't received blina, yes. So he underwent a transplant. He had a post-transplant relapse. Then he got a CAR T, and then post CAR T, then they had used inotuzumab. So it's not always like it's not that straightforward, I would say, because a lot of patients we've ended up just using like 2 cycles of blina pre-transplant to get them to be MRD negative without actually thinking about what would happen later, whether we could use the CAR T or not.
Great.
And at that time, like that wasn't really a consideration. We would always like go ahead with the blina and reserve inotuzumab for later.
So we had this concept when you have a CAR T available as a next line of treatment, people tend to use avoid a CD19 antibody, so that again you are missing on a CAR T. So I think that's fair enough. Now that's going up probably just in question. So in our question, in a relapsed disease, what are the goal of our treatment when we start treating a patient with ALL, relapsed ALL? What should be the goal of treatment? So what are we looking at to achieve with our so-called any drug or therapy related? Santosh, probably you can put forward your thoughts.
Yeah. So if you want to put it simply, to take the patient into transplant in a MRD negative status would be the goal.
I think we are fair enough. Madhav, you have anything to add?
Absolutely no difference of opinion.
So I think everybody is looking at putting an MRD negativity and taking for an early transplant as soon as possible. So the data is very clear. In the Innovate trial, inotuzumab, patients who got inotuzumab achieved more CR and MRD negative. Almost 3/3 of the patients who got actually inotuzumab achieved a CR on MRD negativity. And the MRD status was high in the first salvage. So you want the as early as the best treatment, the first salvage. And MRD negativity was high, almost 87% by second cycle with using an inotuzumab. And the survival, overall survival, and the PFS benefit was high in the patients who had or underwent transplant anything, whoever had MRD negativity. That is, median overall survival was 14.1 and MRD negative compared to 7.2. And the PFS was 8.6 versus 5.4. I think that's very clear. We understood. One thing is MRD negativity as soon as for transplant. And patient who underwent transplant, so median OS was 19.2% per patient who underwent transplant. So the patients who underwent transplant do well compared to 6.2 who did not undergo transplant. And in Innovate trial, it was very clear. More patients actually went for allogenic stem cell transplantation compared to patients who were taking chemotherapy, I think. Now, the biggest worry we have with inotuzumab is, I think I missed that point. Yeah, this I think I'll discuss it later. So the biggest point with inotuzumab was the VOD. So I will come to the VOD later. So approaching the transplant, we are clear on this. So I think this part we have cleared it. I don't want to go back to that. The overall survival is definitely increased when used as a first salvage. The whole data says that using inotuzumab as first salvage tend to have highest, the complete remissions and the MRD negativity is high when you use a first salvage compared to second salvages. 80% of the patients go into CR1 when using in first salvage compared to 64%. Even the overall survival probably is way high, somewhere around 25.9. That's almost 1/4 of your patients survive at 2 years when using first line inotuzumab compared to 16.8 when you use second line. So we are clear in one scenario like inotuzumab, usage of inotuzumab as first salvage definitely tend to give a better survival. Second thing is using inotuzumab compared to chemotherapy, we have a better salvage rate. Now, coming to the bigger issue which we have is the toxicity, except VOD. How are you managing your patients with inotuzumab, probably continuing the inotuzumab, on OPD basis? Are you in the first cycle, are you managing the OPD basis, or is they are in-house in the management? Santosh, you can.
In case they're not having fever, febrile neutropenia, are not toxic, no platelet requirement, I am doing it in OPD basis itself. And if they're obviously requiring antibiotics, I put them in.
So, are you using any prophylaxis when you give inotuzumab to everyone?
Yeah, like we're using the full prophylaxis, antifungal, viral, bacterial.
Okay.
And if the ones the counts are okay, even the anti-PC prophylaxis.
Great. Madhav, how is your practice in managing in OPD basis or?
Yeah, I mean, at least the first cycle, day 1, day 8, I kind of see if we can like put them in for a couple of days. And from day 15 onwards, like from the first cycle and whatever subsequent cycles, if they don't have like fever or any other complications, we try to manage them on a daycare basis.
Correct. I think, the whole concept comes when how you are practicing and where are you practicing. So most of us, because of the busy schedule and the hospital scenario we have, we manage first 2 weeks in the hospital, and probably from third week we keep an OPD basis. Probably that is, and most of our patients, they don't have a place to stay in Hyderabad. Staying, all those things is a big issue. Most of our patients are coming from different places. So that's the reason first 2 weeks we actually keep in-house. And actually, it's a procedure which can be done on OPD basis. And everybody believes in giving ursodeoxycholic acid as a prophylaxis during all inotuzumab or only during transplant.
We tend to use only during transplant, not during the inotuzumab.
Okay, Madhav, you have anything to add?
I started with inotuzumab.
You start with inotuzumab.
Yeah.
We somehow, I don't know, the fear of having, we had issues. So we start after first cycle, we never started. First 2 patients. The third patient and all, we started with the first inotuzumab. After that, I think that experience probably will come to share accordingly. So again, stock question: what is your choice of treatment when tumor burden is very high? That's almost blast more than 50%. You want to add some chemotherapy to inotuzumab, you stick to inotuzumab. I think we are clear. We are using inotuzumab. Santosh?
So I'll definitely just stick to inotuzumab, definitely. And I think Madhav touched upon this sometime back. In the relapse setting, if the blast percentage is more, inotuzumab is a drug of choice. If you have a low burden relapse, then people say that Blina is a better choice.
Yeah, that's MRD positivity.
Yeah.
So, any experience of using hyper CY, because Dr. Kantarjan and group has used?
I have used it for a patient actually. This was way back in 2017, I think. When we first had compassionate access to the drug. I had sent an email to Dr. Kantarjan, and that the JAMA paper had just been out. So we had used mini hyper CVAT plus inotuzumab for a patient. It was quite well tolerated actually. Patient gone to remission, and then he was referred to Bangalore for a haplotransplant at that time. I've used it for like one patient.
Correct. So I think single agent inotuzumab holds. Then we had an issue. For some reason, we used in 13 or 14 patients inotuzumab. Last 2 patients where tumor burden was more than 90%. This last patient where we had actually given some chemotherapy after as a first salvage, he was refractory. Then we had a very high tumor burden. WBC were 3 lakhs, 2 lakhs and all. That's the time we actually used hyperfractionated cyclophosphamide, like hyper-CY. And day 4, after a small dose of adramycin, like mini hyper-CY, we used inotuzumab. That's the only patient. Though we achieved CR and all, and we took a transplant. And unfortunately, day 100, day 200, day 110, I think, day 110, he had a CNS relapse, and unfortunately, we lost him with the progression of disease. So yeah, hyper-CY with a very high tumor burden with inotuzumab is again we used in one patient, but most of the patient, I think single agent inotuzumab, I think we have most of us are using the same. I don't think so. We are different in scenario, and the data says inotuzumab used in any scenario more than 50%, less than 50% blast or more than 90% blast. It has the upper edge compared to transplant. I mean, compared to conventional chemotherapy, the numbers are staggeringly high. And MRD negativity also is high when you use inotuzumab. And somehow they analyze the VOD data also. The VOD data somehow paradoxically is high in patients who are less blast compared to less in patients with more than with more blasts, probably it's now a number game. There are less patients with more than 90% blasts. And the overall survival was improved with whatever blast percentage they presented with, less than 50% or no more than 90%. Yeah. Now coming to the bigger problem, I think, yeah. Long-term survival, I think we are not old enough to have a long-term survival, probably have relapsed. Most of ranituzumabs have come 3-4 years back. I don't think so. I probably will be very happy to listen whoever has the long-term survival in your scenario of using ranituzumab. Anybody, Santosh?
Yeah.
This is a stock question given to me, so I have to ask.
You should answer that first because I think you are the one who has used most ranituzumab.
Yeah. So to be very precise, I have used in 13 patients right now. And the longest surviving is 2.5 years. But that guy, to be very off the records, he's not on things. It is not about a relapse setting. It was an upfront setting in 69-year-old male with a pH positive pH positive ALL. So one of the guy, doctor was in US who was his relative. So we started with dasatinib and anituzumab. And he's surviving with, again, it's not a relapse setting. Now, coming to relapse setting, unfortunately, I could, out of this setting or 5 patients, we could transplant them or relapse setting. Only one is surviving. One I lost because of VOD on day 38 VOD. He engrafted and unfortunately I couldn't. Another patient got a VOD, but day 100 relapse. Another patient day 112 relapse. One patient died of a GVHD, grade 4 GVHD. I couldn't salvage him. He developed a HUS or MAHA secondary to GVHD and multi-organ dysfunction. So post-transplant, only one guy now, day 200, is surviving. Most of the patients, one VOD and other patients, 2 patients relapsed. Probably the biology was very bad. These guys had salvage. Second salvage, I used inotuzumab, unfortunately, and took him for transplant. And all were by default haplo. All 5 transplants were haplo. Nobody got a mud. Nobody got a mass sibling or a mud. And all were issues. So 2 patients had VOD. And that first VOD only taught us to give time between last inotuzumab and our transplant. So out of the 13 patients, 5 patients we couldn't take him for long. They were not ready for transplant. 2 patients probably upfront, and 1 patient I think didn't respond. 5 patients we took for transplant, 1 survived. That's the maximum. So no, the only guy who's surviving 2 years is a guy who is upfront with a pH positive disease. That's my thorough data. Anything, Madhav, from your experience?
How long do you wait between the last dose of inotuzumab and the transplant?
Yeah, that was the question. Actually, I wanted to put a stop question for you guys. So first, again, the experience is all from learning, man. When I started 2 years back, the first transplant and all in post inotuzumab, I actually waited for 4 weeks. 4 weeks, all these 4 weeks, 2 patients developed VOD. One guy had a grade 3 VOD, which I had to take him defibrotide for a long time. Another guy, other female was a grade 1, grade 2 VOD, which could manage. After one bitter experience, I give minimum 2 months, that is 8 weeks of gap between the last inotuzumab and the transplant. I give a bridge therapy. After 4 weeks, whatever patient in remission, I give a bridge therapy and take him for transplant.
What do you prefer? Like, what do you give usually, like in the
bridge
interim?
Therapy? I get you.
In the interim, like in 2 months.
Yeah, some stock we have BFM and hypercVADs, when some harm we give. It's just playing around. There is no stock bridge therapy, whatever as a thing is available. So one patient had a CD20 and CD22 positive. So a CD20 guy, after inotuzumab and CR, I gave R hypercVAD, one of the arms, to get a time. The other patient, I think, was some of the chemotherapy, the induction phase 2 cytarabine cyclophosphamide to buy time. Just to buy time. So just to get a 2 months or 8 weeks of gap between last inotuzumab and the transplant. We had a discussion in one of the forum with one of the Asian groups who actually use inotuzumab commonly with availability and all. They actually don't. They wait only for 4 weeks. For some reason, they only wait for 4 weeks. And the best part is they use prophylactic defibrotide to prevent VOD, which probably we are not in a scenario to use prophylactic defibrotide.
Do you procure your defibrotide vials beforehand, like, or do you?
No. I think everybody is same. We though tell patients, first patient we never told him that he may require. I told him there is a possibility as a VOD as a part of our regular thing. It's a learning experience. I knew there was some possibility because I have not seen a VOD till then, man. Though we have done 200 and 300 transplant, most of the VODs were manageable. Never a VOD which I thought was a grade 3 and grade 4 with multi-organ dysfunction. So after that, yes, we plan most of the patients, we tell them availability, but we don't procure. Now the availability is not an issue. I think we call probably within a day you can get a.
Within a day, yeah.
I may differ. It's again learning experience. Nobody's. We are starting with most of the things. I somehow feel the VOD rates are high in India. Because you have noticed the PEG asparginase induced hepatotoxicities are comparatively more reported in us than Europeans and other Caucasian countries. So same reason the VOD somehow tend to be slightly high in our population because we don't have big data. If you actually put forward, the VOD will be very high in our scenario. Same, probably our diet and NASH. We have a lot of NASH and low albumin.
And do you try and complete the cycle of defibrotide? Do you like give it for 21 days, or do you like reduce your doses, give it for a shorter
maximum
duration?
is 5 to 10 days.
5
they
to
would
10
have finished
days.
that. That's the man. Again, it's a bias. We are in an institution where the half is supported by the government, the rest half is the patient.
Yeah.
Most of the patients don't come to us with full. They are not affordable to go for transplant. It's half money both ways. Probably I am in a scenario where people cannot afford defibrotide after 1 week or 10 days. And I'll be very happy if you have any experience in that way, probably. Santosh.
So the patient which we used inotuzumab had VOD, and the VOD improved after defibrotide. However, subsequently, any patient who gets inotuzumab, we have decided to go to transplant with a prophylactic strategy. And I feel the risk is too high, especially if you are given 2 cycles of inotuzumab. And I mean, if they can afford the inotuzumab, they may as well afford defibrotide also. And hopefully it will be available in Indian market soon from one of the Indian companies. That is the feedback I got at the last APBMT meeting.
Okay, so you are using a prophylactic inotuzumab.
Yes.
So that's so you are happy with you're able to avoid VOD.
The subsequent patient didn't have any VOD. So
you wait for 4 weeks or you go wait?
No. I agree with you. A reasonable gap of 4 to 8 weeks is something that we should target.
Have any of you had issues with bleeding with defibrotide? Like,
no. Yeah. So I mean, we have used a lot of defibrotide in various settings, even in TTP.
Correct.
There was we published defibrotide use in TTP. So defibrotide at a lower dose of 200 mg BD is something that we use. Even at that dose, there is a risk of bleeding. So it's important that you keep the platelets a little higher when you give the defibrotide.
So that's what same thing like Dr. Santosh has put forward. We also use in most of it. So I used VOD more in TTPs than the VODs for some reason. So TTPs had been an issue with me for haplotransplants. Bleeding, I had somehow like we use low dose TTP. So low dose defibrotide. Probably I never had an issue against a bias. Numbers are less, not as so. VODs we have only VODs with inotuzumab. When I had a VOD before.
And what protocol are you using, sir, for your haplos? Like your
So we started using most of the myeloablative initially with the TBI flu. So all 5 transplants were initially with TBI flu, and subsequently now with over the time things. I think the last transplant, all 5 transplants was TBI flu. The only thing is the dose of TBI reduced. We are going in more in a RIC between RIC. So somewhere initially we started the 12 gray thing. So we came down. The 12 gray was too much toxic. The first patient we lost was the 12 gray with VOD and subsequently. Then we reduced. We came up to 8 and 10. Because all ALLs per se with other any protocols, it's been in. We have tried using trio and all, but it's been inferior in the previous haplo transplants when you use non-TBI based. So we are sticking to TBI. We're doing TBI flu. I think Santosh, you have.
Till what age group do you give your TBI? Do you have like a cutoff beyond which you avoid giving your?
That's what age group in the sense that the dose of TBI is a cutoff for us. Okay. So most of our patients are more than 20. So age, so we probably don't cross, once you cross 40, we don't cross 8 grays. So that's something like reduced intensity conditioning, 6 grays.
So you prefer lowering the dose of TBI than switching to a
correct. That's
a different regimen.
Again, that's the way we were doing haplo. So I thought TBI is more easier for us. So my pediatric colleague somehow there they use TBI in and out. There is no reduced intensity conditioning there. So in the pediatric groups, sometimes they shift to a trio flu Tiotepa protocol. Tiotepa is too expensive for us in our scenario. So we are sticking to typical TBI. I mean, again, it's a bias. Probably, Santosh, you want to add something? You have.
So our haplo protocol is flu trio 2-grade TBI or 4-grade TBI, or flu trio triosulfan Thiotepa with 2-grade TBI. Because we are not doing a TBI, I would love to do TBI based conditioning. Only reason is the bunker is too small here for a TBI conditioning. So there is a new bunker we are building. So we are looking forward to doing a TBI based conditioning transplant. So we will get in touch with you for if we need any help.
Sure, man. So that's all our haplos. That's more than 40 haplos in the last 2 years are all TBI based in ALL. Yeah. We are good enough. So, but I'm only think reducing the dose has helped us. Nothing else.
Right.
So, moving forward, I think it's more discussion about you and us, what's going on. Yeah, I think most adverse effect in our experience and VOD incidents and what are the status to minimize. I think most of the things we have spoken, and anything else, it's an experience. Again, what you guys are looking at, anything different from what probably literature has not given.
So, what is your experience of viral reactivation, Dr. Pawan? This because I found viral reactivations very difficult to handle post inotuzumab, like CMV, EBV, adenovirus.
Somehow, yeah. So most of the haplotransplants, that's the problem, and I have done all haplotransplants, and I know. So we have everybody had tend to have. So for us, when we reviewed our data, 80% of our CMV, haplotransplants have a CMV reactivation. So all these 5 patients we had a CMV reactivation. EBV, we tend to give rituximab when we don't cross the 6 gray barrier in TBI. So to avoid EBV reactivation, day -5. So that we never had a EBV reactivation. Probably nobody lived for, except one patient, everybody had an issue, 100 relapse and all. We never had an issue with EBV reactivation subsequently. And we don't check preemptive EBV. So we check only CMV. CMV 100% reactivation. Everybody had a GAN cycle.
Right. I think that's more to do with the haplo data, right?
Yeah. That's the problem. That's what I'm saying. The bias is haplo. I don't have a mass sibling donor transplant in inotuzumab to even answer Santosh's question.
No, Pawan, I think it's more to do with inotuzumab because in other diseases where we do haplos, I have not seen so much viral reactivation. There is definitely more viral reactivation compared to a matched sibling donor.
Correct.
However, the reactivation, the virulent reactivation that we see in with post inotuzumab, I think is due to the B ablation that you see with inotuzumab.
Correct. So you guys give some sort of rituximab preconditioning in a reduced intensity conditioning, non-myeloablative?
No, and we haven't done that. But in terms of virus, we have decided to ensure that we check preemptively for adeno, EBV, and CMV, if not for other viruses. At least these three, once in a few weeks, at least just to make sure that we are not missing something.
So we had this issue with hemorrhagic cystitis in transplants, but once we shifted to busulfan to TBI, that's the reason mainly we shifted to TBI. TBI actually made us life more easier for hemorrhagic cystitis, which was a big issue when we used flu and melphalan or tiotepa somehow, and tiotepa came play, and it's too expensive as a conditioning for us when you add tiotepa. So
correct.
I think these are the most of the things what we have discussed. So even the trial, Innovate trial with the transplant, almost 23% patients had a VOD, and in the 23% patients, 20%, 25% was the mortality. 5 patients lost in that 18% patients who had a thing. I think the factors which avoid VOD as a time, using the dual alkylating agents, I think most of us are not using pre-transplant bilirubin level. Do you check any hepatology opinion before transplant for these patients? We're looking for a NASH, fatty liver, and all those things. Or we're doing as a protocol because we are a single institution. That's the biggest problem. We tend to take decision by our own. We don't have a support system. I think you guys are working in a multi-specialty. Probably you can put in an idea. Fibrinohistogram or something like that.
So we have been doing hepatology consultations with fibroscans for patients who do get who are planned for inotuzumab and transplant.
Oh, great!
And one additional thing we have started doing is for many years we never did an ultrasound abdomen before transplant, not part of the pre-transplant conditioning workup. The ultrasound abdomen is something we've added recently because many patients we realized have some hepatosplenic candidiasis that happens during induction that we don't pick up, or for example NASH, as you said, with that also we need to be careful about in inotuzumab.
Correct. Madhav, what's your experience?
I do an ultrasound for sure. I haven't done the elastography, but maybe that's a good. That's a very good idea, actually.
Again, we have a teaching institution bias. Most of our ultrasound done by residents, so we don't believe it's NASH or not. So that's what elastogram. That's a big thing. I think 3 is I think the whole thing, the SOS increases with the number of inotuzumab we use, and I think we are doing that monitoring. But I think we are not avoiding azoles, right? What's your take? Azoles in the prophylactic fungal? Are you guys sticking to echinocandins during the
start with micafungin?
You are going with micafungin.
Yeah, going with micafungin.
Santosh?
Me too. I am so petrified of VOD with this inotuzumab. I would rather do everything very safe.
Okay.
Because it is too traumatic to see the VOD during the first transplant phase. And getting defibrotide, calling abroad, getting defibrotide, it's painful.
First experience actually made us realize. I'll never forget that guy, what we went through in the whole scenario. But he engrafted and VOD, we couldn't get it out. Yeah. And I think cost effectiveness, did you find cost effective when you use of inotuzumab compared to your chemotherapy? Santosh?
Yeah, definitely. Definitely it's cost effective. Other point with respect to VOD prevention is to ensure that patient is negative, you don't all those things that the regular bread and butter stuff that we have to do to reduce the risk of no weight gain, to keep patient active, all those things, keep an eye on the fluids, etc.
How often do you do?
Yeah, but in terms of cost, we are very safe that way. We do LFTs twice a week. Once a day at least.
Okay. Oh, once a day LFT. Okay. We somehow pick it up whenever there's a sort of weight gain and all those things. We do weekly once or weekly twice. That's correct. Sometimes it's better to be more cautious than. So it's more for us. It's more cost effectiveness because
Right.
the state government is paying us, so we need to save our state, right? So somehow we tend to reward.
Correct.
Madhav, you have anything to add? The cost effectiveness of inotuzumab?
No, not really. I'm not in the appropriate setup.
Oh, okay. So wrong question. Probably, yeah. I think yes, the hospitalization comes down and the thing. I think I probably will stop somewhere here and take it from here. What are the other experience? So you have a what's the experience of blinatumab compared to inotuzumab? Because blina is not available in the country. Yeah, it's a difficult drug to give. Santosh, for you have an option of both. You have a patient who relapses early. Both options are available, and he's ready for anything.
As we discussed previously, blina is only for clearing the MRD.
Okay.
And again, but with this very impressive data with blina, with ponatinib in pH positive ALL, it's amazing data. So I mean, those are upcoming areas, but in the relapse setting, only to clear the MRD.
Madhav, you have anything to add? Because probably you worked in Vancouver for a while, you will know.
Yeah, so blina, that was the only setting we used to use it like uniform to get them to be MRD negative.
I think that's the first approval it got it for
yes,
this. Yeah.
Yes. Also, what's your opinion on lowering the? I mean, like you know, there are a lot of like trials like with inotuzumab and combining them with chemotherapy, right? Like,
yeah.
Going with a lower dose of inotuzumab, combining it with chemotherapy. You think that's better option than just give like single agent? I know.
So that's the thing. So most of us in the era, so I had used two patients blinatumab. This was an era where inotuzumab was not available in India. The import of blinatumab was somehow cheaper than inotuzumab then. So that's the reason we had to use. This was in 2017, I think 18, 19. So blinatumab then, the two patients. Yeah, it's very cumbersome. And subsequently, though they went into remission, like we could transplant both of them. Again, same, the biology was bad, both relapsed. That's a different story. But now in the availability, yes, inotuzumab, but always a person who has seen a VOD post inotuzumab will have a second thought, whether can I use a blina? That's the whole scenario. I think the guideline says the same, even in extramedullary disease, that use of inotuzumab tend to show benefit. This is a question I have. Probably we all are here, so probably it's my anyway, away from inotuzumab. I have a patient actually I want to discuss. Probably put it forward in a simple manner. We have a 2000 young guy. He was diagnosed at 12 years, pH positive ALL, 2016, 2017. So that time I used a COG protocol to avoid ALL. I think COG ALL 0031 protocol, where we avoid a transplant. So we used imatinib with one of the intensive treatments. He was fine. 3 years DFS. He had a first CNS relapse. It was in somewhere in 2018-19. So we did again intrathecal therapies and we gave prophylactic RT. Then post that we get therapeutic RT. Then that time we had counseled them probably to think for a transplant and all, but somehow they were not agreeing. It was going on. So again, 1 year later, he had extramedullary relapse this time. It was a 4 years DFS from the first time. And so this guy we again salvaged with conventional chemotherapy with ponatinib this time. So he had actually imatinib, then CNS relapse, we shift to dasatinib. He progressed on dasatinib, so we had to put ponatinib and some salvage chemotherapy. He was in complete then CR2. Then we took him for haplotransplant. I could go up to 10 gray of TBI and flu and so he was doing fine. 1.5 years down the lane, he again relapsed. So ponatinib was a maintenance we gave for 6 months post-transplant and we stopped it. So he had a CMR for 1.5 years. Then he again relapsed on the CNS. This time again a CNS relapse. Only CNS relapse. Again, B lymphoid. We have been giving some sort of chemotherapy. We gave methotrexate, citrab in some arm, and then we did a DLI. It was again fine for 3-4 months. Again, he relapsed. The CNS is a persistent disease over the time with no medullary disease, CMR, complete molecular response, if you take the pH. So he is almost 7-8 years from the diagnosis with only persistent CNS disease. Have any thing, Santosh, you have anything to add? I am stuck with ponatinib. I restarted ponatinib though.
Very interesting.
Very
interesting.
I don't know. I'm stuck. So anyway, I thought you and Madhav were there. I'd probably ask you guys what is it. Everybody, I don't know what else to do.
I'm not sure. So I'm not too sure if there is any data with asciminib. You can look it up, or you other thing you could do, I feel, is you could do CART, and the CART has definitely CNS penetration.
But problem is putting a card, will you fit into the protocol? If you even see, last time we discussed, we are one of the PI for the CAR T cell therapy. But the whole thing is you have a CNS disease, so you are out of the protocol. Commercial card,
Is it?
Not yeah.
You should, I mean, okay, let us check it. I'll look at the inclusion/exclusion criteria.
So because last time I checked, it was again CNS disease, you are out of card.
Right. Okay.
So I think that's the only thing. CAR T is the only option we have, probably. Yeah. So I think you also, anything, no Jugaad values we have. Okay. I think we have reached almost 7. So I don't want to wind it up. So thanks, Dr. Santosh and Dr. I think Madhav is not seen here. Thanks, Dr. Madhav, for it's a really, educative thing. Even for me, I learned many things from you guys. Whatever things we are doing is small stuff, but really speaking to more people who are doing more other stuffs, I think we are getting educated. So I want to probably I have to put some closing remarks. So that's what, Mr. Sanjay, should I start with the closing remarks?
Yes, sir. Please, sir. Then I will take over.
Yeah. There is nothing add to the closing remarks. So right now, anyway, in the relapsed pH positive, relapsed BLL, in the era of availability of monoclonal antibodies, and with only inotuzumab available, and which probably is the best right now, I think, and it's taken the whole scenario forward. And with the usage of inotuzumab and understand the toxicity, probably we'll salvage more patients and do it in an easier manner. With CAR T, which is a backbone, probably even patients who probably fail, or probably we can get a cytoreduction before a CAR T. Probably a transplant will slowly move away from transplant. If a CAR T becomes an easier thing available, still inotuzumab will be probably a better cytoreductive regimen there also, who can go for a consolidatory CAR T cell therapy. Thank you all.
Thank you, sir. Sorry. Sir, thank you so much for wonderfully moderating. I extend my heartfelt thanks to Dr. Pawan Kumar, sir, for moderating the session. I thank Dr. Santosh, sir, and Dr. Madhav, sir, for extending your expert opinion on a very important topic. I also thank all the attending healthcare professionals for this virtual meeting. Thank you so much, sir. We look forward to hear from you on the virtual platform soon as well, on a scientific platform event. I also thank the Thanks, sir. I thank the technical team who helped to run this meeting. Thank you so much.
Nice, Santosh. Thanks a lot. It was fun speaking to you. Yeah. Bye.
Thank you, sir.